Hello, this is Willie Tiniswa, CEO of Open Wound Research and the host of the Open Wound Research podcast. And today I'm very excited to welcome Rob Fraser to the podcast. How are you doing today, Mr. Fraser?
I'm doing very well. Thank you so much for having me.
It's my pleasure. It's my pleasure. As a first port of call, I am really impressed by your camera quality. Uh, Coming on the show and showing me up in 4K.
So, as I'm sure we'll talk about, I'm into wound photography, but I'm also a amateur photographer. So I do try to make the best use of my gear when I'm not out on trails or using it for that hobby. I try to use it to get a little bit better experience for all of my virtual work.
No, it looks great. You've got me a little jealous, which is a common emotion when it comes to camera equipment. So I might need to look at some new equipment to keep up with you. Uh, but let me do the quick introduction for the audience today about Rob. I'm very excited to have Rob on. Rob, I think, is one of the most interesting young people in the research community. I am amazed more people don't know about him. Love his work. He's always engaged in the community. And I just think today's episode is going to showcase his knowledge in wound care, which is pretty extensive. So, Rob holds his nursing degree from Ryerson University. He also holds a Master of Nursing from the Lawrence S. Bloomberg Nursing School at the University of Toronto. He also is currently the VP of Clinical Innovation at Swift Medical, and we'll talk a little bit about his role there in a little bit. He's also sits on multiple committees, models of care of young parents, the VON Canada committee, which I believe is for home health, which he sat on in 2011. He's also sat on the curriculum for quality improvement at the Western University, which is also in Canada, and the Chiropode, hopefully I'm saying that right, Program Advisory Council at the Mission Institute at the University Health Network, which he currently sits on to this day, if I'm correct, right, Rob?
That is correct.
Perfect. All right, so let's jump into a couple of things you're doing. So, in your current role as the VP of Clinical Innovation at Swift Medical, what are the kind of things that you're doing, and where's your interest in nowadays?
Absolutely. So, Swift, for those who haven't heard about it before, is a digital wound management solution. And within the company, my role leading the clinical innovation team is threefold. So, the first is we get to focus on projects that accelerate growth. So, this can be grant funding, special projects, working with our research development team on hardware, software, AI, machine learning research, and our product team also to translate ideas into the solution and to try to push those forward at a faster pace. The second element is evidence based outcomes. So we've been very fortunate to have wide adoption across North America and over 21,000 clinicians using our software per month. But what is the actual impact? And I have a team member, Dr. Habatullah Mohammed, who looks at the actual clinical, financial, and operational impact of adopting a digital wound management solution. So we try to come up with that evidence based understanding above and beyond just a demo of an application, but what is the impact that we have for wound care programs using our tech? And then finally, data driven insights. And I think this is where you and I have had a lot of good conversations. I love data too. And so one of my team members is focused on driving insights for that. So, how can we leverage the data warehouse that we have, that data lake, for internal understanding of how our customers, clients are adopting that technology? What is happening with the documentation, the performance of the application, and then also thinking how do we create better dashboards for organizations using that information? Because data is information when you translate it correctly that should drive action, which can help with changes for wound care programs. So that's an overview of the portfolio that I hold.
That's brilliant. I think we have plenty to chew on, given that description. But before we do that, you didn't just kind of fall into this role. You have had a lot of experience as an adjunct professor. You were the director of clinical services prior. So, if you could you give us your origin story in wound care? How did you arrive in wound care, and when, and how did you kind of uh, get to the role that you have right now?
Sure. And maybe I can back it up a little bit before I even talk about wound care and talk about technology. Because my career has always had two levels to it. One, the clinical pathway of my development as a registered nurse, gaining the skills in my education and experience in my career. And the other has been applying the use of technology throughout that. So one of the things that I had the opportunity to do during my graduate school was to write a book about how nurses could use technology. And that innovative technology at the time was social media, this transformation of how the internet could be used. And instead of talking about just the risks of it, which was nurses getting fired, I was trying to talk about professional engagement, professional development. How can we support patients and educate them or change our systems? So that was always a thread throughout the work that I was doing in my career. And wound care started to be stitched along with that thread early on. So when I was in my undergrad finishing out my placements, I was working on multi-organ transplant at Toronto General Hospital. It's the largest hospital healthcare system in Canada. And there was a patient who had a wound with a very intricate dressing. It was quite painful on his foot. It took over an hour to undress, cleanse, treat, and then rewrap it. So when there was an oncologist being consulted, he would come from across the street at a neighboring oncology hospital and would not want to take off that dressing to actually look at the wound. And the patient was getting frustrated with this kind of happening a few times. And when I was caring for this patient, he noted that I had the iPhone 2, the first iPhone that came to Canada, and it had a phone and it was connected to the internet and it could send images. And he said, "Hey, could you send an image, because you've been doing this dressing change, to this doctor who's trying to see it?" And immediately I was like, that makes so much sense. And I took some photos, I sent them off, and the physician sent me back a nice thank you note. And I was very proud of myself for this. And so then I go and show my nursing preceptor, and she says, "Oh, Rob, what did you do? You've just broken the policy on sending information via email, and I want you to write a reflection paper on why you're never going to do this again." And so I did that. And that was in 2009. So in grad school, a few years later, there was an engineering course that I had the opportunity to take to make a mobile application. And I got to work with two engineers who got to develop a project based on the non-engineers experience. So I said, I want an application where I can securely capture wound images. So we built and made Wound Capture. And it was a terrible application. I wouldn't necessarily want to use it myself, but it was starting down this path of saying, oh, what clinical documentation has to go into this? How do we capture information? How do we annotate images? And so then a few months later, I go to a hackathon, and a medical student at the time is at a research hospital just up the street. And she says, I need a wound application because we have all of these wounds and we have no great way of tracking them. So I said, oh, I just spent 3 months in my semester researching this. I'll work with you. And we won the most practical application of the weekend, which I thought we should have done better. Like that to me, it's a participation winner prize. Like I think it's game changing because I love wounds, but nonetheless, she carried it forward for a bit, but the developer from the project hackathon is committed to his work, didn't want to move it forward. So it kind of is on pause. And I go back to my pathway of working through my clinical jobs. And about a year later, she gets in touch with me and she says, Rob, you have to see this demo. I found this group and they've made it. And I met with the CEO of Swift and he shows me the demo of Swift before it had gone anywhere. And I said, this is what I was looking for. So that's what brought me into wound care. And so I worked with the founders in some of the early days because they were people with technology skills, building some of the things that I wanted to see. And that's what really continued to bring me towards wound care is the opportunities that I saw with technology to truly make an impact. And it kept on coming up because as a nurse, whether I was working in the hospital setting, I worked in community settings, I worked in home health, wound care was seen throughout that trajectory of the wound care continuum. So I was always a little bit exposed to it. So when I had the opportunity to join full time, I was really excited to dive into this role that fits my interest in clinical and technology very, very well.
Sure, that's it's interesting because I didn't know that Swift was your first stop. So you know, kind of in wound care, I should say.
It was definitely my first full time role that was dedicated to it. So when I first started working with the co founders, I was part time and I was running a clinic for street involved youth. So primary care, mental health, addictions. We had psychiatrists, family docs, and nurses, and that was my full time job. and this was a new startup. So I was finishing at the clinic and then going over to the innovation buildings at the university and helping them with anything I could because I wanted to see this come out as a clinician. So I was dedicating my time and supporting them as a kind of first part-time employee to work with them, and then saw them grow the team to 9. And after a year, there was so much work that I couldn't do both. And I was at a point early in my career where I didn't feel comfortable giving up clinical practice yet. So I said, I'm going to keep on doing this, some of my clinical journey. And then 2 years, 2 or 3 years down the road, I had picked up leadership of programs, implementation in home health, and the pandemic had just hit, and I was looking for a change. And we'd always talked about working together because I loved working with the co-founders, had a great experience, and that's when the door opened back up because I was looking for a role, and I was fortunate to rejoin full time, and I've been here the last 4 years.
So, a question that kind of pops into my head immediately is you are a clinician by training and a technologist by adoption, we should say. What are some of the challenges that you've seen between this tension of technology on the one hand, where technology has these superpowers in a sense, efficiency, immediacy, accessibility, versus the reality of care, which tends to be slower, be a little less digital, and there are also laws, etc., that you have to be mindful of. So, how have you guys thought about that? How do you think about that, and how do you balance those concerns?
Absolutely. So from a personal perspective, that was my message in the book that I wrote is technology has a tremendous opportunity to help clinicians, but we need to be involved in understanding them and determining how we adopt them. And so I support graduate students regularly and try to give them exposure to what is it like to be a health executive inside of a digital wound management solution so that they can see that there's more opportunities for nurses than just being a nurse educator or a manager. Because if we want the technology to fit into our practice, our voice needs to be at the table when it's being created. Because if it's only at the showroom floor, or worse yet, if it's only when the organization is rolling out technology, that's where we can run into challenges and the negative experience can happen because clinicians aren't being included. So, from a day-to-day perspective, in my current role, we take clinician input very seriously. We have uh, focus groups and intakes and user testing sessions to make sure that we're understanding them, and always trying to thread that needle between understanding what the clinicians expect and how can we delight them with things that they may not know are possible in the future to address things that they're expressing but they don't necessarily know how to solve.
Sure, no, that's great. At Open Wound Research, we focus more on the data and the statistical. And there's two schools of thought on the statistical. There's the pure data driven approach, which is the data tells you everything. I don't really subscribe to that. Anyone who particularly works with data finds that there's a limit to how much a data can tell you on the one hand, and on the other hand, the data can lie to you if you don't know what the data generating process is. And so, sitting with clinicians and saying, what is the science? Like, in your mind, how does this model work of what the data is showing or what the data is implying? And then picking that apart and then putting that into the model. And I think, the superpower of technology, at least in my mind, is the ability to take the learnings that we have as humans, build a model around it, and then iterate with the human to arrive at the next aha moment. And it's a
Mhm.
slow, iterative process, but you can't take the humans out of it. And the more we try to do that, I just see bad, bad, bad things happening. So I'm
Yeah.
glad that you sit at the table and you drive that conversation because I think that's invaluable.
Yeah, and that's why it was so humbling to even be invited on this pod. To be honest, is I listen to every episode as a learner, as someone who's early in my career in wound care and trying to grow my expertise. And I've messaged you many times about how much I enjoy the show, but I'm always trying to learn about it. And what I see as important in my role as a nurse and with a clinical understanding inside of my day-to-day work is helping some phenomenal R&D researchers who do brilliant things with machine learning and AI that I'm scratching the surface to understand. And you talk about Bayesian statistics with Melissa, and I get lost, but I get fascinated and I'm trying to follow. And in the circles that I work with, I'm always trying to help translate the understanding of they see the data, but what does it truly mean? Because they can run a model and it can give an output that may not make sense to a clinician. So I try to help in that translational work to make sure it does edge towards something useful. Because if you only have people working with a data set in isolation, you can have brilliant R&D minds, but it's very challenging to come up with something useful. Whereas when we sit at the table together and they tell me what they see, and I'm able to express what I think that can tell me as a clinician, that's where we start to make progress. And I light up when I get to join those meetings and be part of those projects.
Can you give an example? Again, I don't want anything that's proprietary, but can you give an example of where you had an insight that perhaps your AI engineers or your R&D people were not picking up on, that you brought to the table, that really kind of gave them that eureka moment?
I'm trying to think of a specific example. Like one of the projects that is close to my heart because we're working on it right now is smart tissue. So, how do we actually get AI to classify and predict wound tissue types, and helping the engineers and AI researchers understand what is the difference between those and what is significant has been really helpful to advance that and to move forward the validation of looking at the predictions that the algorithms are making and how that can shape the usefulness for the clinician. And some of the things that I try to do, for example, is saying, okay, if you look at a BWAT evaluation or all of the things that we could automate, which are the most useful ones, which are the more challenging ones for clinicians. And in smart tissue, we're looking at simply the four tissue types inside the wound bed: slough, Escher, epithelialization, and granulation, as a base label for predicting and helping understand, is it shifting towards healing, that granulation tissue forming. And we don't want to use a color model because you can have fascia, you can have blood. If you're only looking at the color, is that truly predicting healing, or is it something non-significant? So going through that process of helping teams label images correctly and get 17,000 images trained that we can use in the model is what clinicians can bring to the table, so that those training elements can be better and we can help address the challenges to getting this correctly documented and consistently documented.
That's pretty cool. Those image algorithms have become, I mean, I remember on GitHub when the first models came out for image classification around 2012, and they were bad. I mean, it was bad, but it was amazing because you could machinify something that humans almost do intuitively. And in the past 10 years, just the open source models are just, I mean, they're next level, and many of them are production ready. I think in wound care, it's become really interesting because having the image and really understanding how tissue drives healing is important. But I built a Bayesian model because I was playing with this idea of, if you have these proportions, right, of tissue, there's inherent uncertainty, right? There's
Mhm.
inherent uncertainty at the human level, there's inherent uncertainty at the machine level. And you might have two patients, same tissue share composition, but one is headed towards healing, one is not. So, how do you capture that uncertainty given the same observed data? Because you can't really, if you think about the nature of tissue, right? It's a non-discrete mixture of things. And so, even humans, it's hard to classify what that even means. And so, I've dealt with that problem. That's a complicated problem to deal with.
Yes, absolutely. And it's one of the interesting things to get into the adoption of algorithms as well. And we looked at things inside of one of our prognostic models. We call it healing index. It's creating a wound severity score for that wound. And when they were doing the training or development of the model, we were looking at of all the information that we have from across our 50 million wound assessments, 28 million wound images, and all of the data that we have, what's the most meaningful so that we can build the simplest model. And we compared objective measurements or computer-based measurements for area and for tissue typing against clinician documentation. And the automation is much more predictive, to the point where the tissue types were not included in the models because there's so much variance, because the clinician has subjective assessment. And the question is, one, do they have the education? Do they know what these tissue types are? Two, actually, is the measurement. Can they actually accurately assess that that's 13% of the wound bed versus 15 or 16? Some of the scales that we use just put it into quartiles, which is pretty big buckets. And the models couldn't pick up significance when it changes between clinicians because of that subjectivity. But even though a model may not be perfect, or clinicians may rate it as a good, not very good in terms of acceptability, the fact that it's consistent every single time takes out that variability. So how can we use those to help clinicians say, you can skip this step, but it's actually more useful? And we're doing work around how to get clinicians to understand the variability, because, for example, if we look at the feature of auto depth, we can measure depth without touching the wound by creating 3D models of the wound with photography. And you can validate that against an engineering laser. And you can say, this is ground truth. But with tissue typing, there's no true laser or objective measurement that I can buy to say this is going to be ground truth. So we've been surveying clinicians to look at the variability, just so we can show back to clinicians and say, this is what happens when clinicians rate the same image multiple times, is you get these wide ranges. So how can we move to a more objective, consistent measurement over time? So there's so many elements to developing the model, getting people to accept the models and deploying them. Because to your point earlier, there's a lot of models in research, but how do we actually get them into practice is something that I'm very focused on, because it can't just be a research paper that does it once. We need these tools in practice.
No, definitely. I love that problem. Maybe these distributions ring a bell, but the Dirichlet process on wound composition. Dirichlet is when you have proportions on non-discrete data. So I'm assuming there's a Dirichlet process algorithm that's running, or you've attempted to run.
Yeah, the statistic part, I will say, I do rely on the AI researchers to manage more, because I have to pick up on the implementation of the other factors, and I don't have that expertise. But that's where I'm, again, continue to pick up on the early understanding of, is it a machine learning model, and how is it kind of processing, and what's the output?
No, that's good. Yeah, I could nerd out about that all day. It's fascinating. It's fascinating, and then going back, I love going back to clinicians and saying, oh, does this answer the question better? And when their eyes light up, I get excited, probably like most of your team does when that happens. So let's delve a little bit more into some of the research you've done, which again you've articulated real world implementation of models into. Well, actually, let's go back one step. What kind of settings are you guys predominantly placing the technology and the algorithms? Is it post acute or acute or home?
Yeah, we've had widest adoption in post-acute. We have very large penetration into skilled nursing facilities across North America, and home health organizations. We work with some of the top 10 providers in the US in both of those categories as well. We have some small hospitals using it as well, but that's a growth vector for us.
Okay. And what are some of the big differences that you've seen post acute versus home health in the implementation of algorithms? And where have you seen where clinicians are getting the most lift from using the tools that you guys build?
So there's benefits in both, and one of the differences in the residential care settings is just the longevity that they have patients for. So your understanding of them is much deeper and broader, which is fascinating. And in some of the papers that we've published, we've also focused on the wound prevention side of things as well, because in those facilities, yes, you don't want to treat wounds effectively, and we provide objective measurement, collaborative tools, and things that help that. But also the screening and understanding of who is at risk is very important to those organizations. And in the home health side of things, it's very operational, and giving them the insight that they have, whether they're operating in a region, some of our clients are operating in 50 states, the ability to oversee that program and to truly escalate risk to those limited resources, wound care specialists, to oversee programs is very, very helpful to help with that collaboration and understanding of the management and the quality issues in terms of which locations or facilities are having higher rates of wound deterioration or challenges managing it for home health, or in the skilled nursing landscape, which facilities have higher incidence and prevalence. And I know you're previous podcast with Jeannie McGuire, she talked about, again, having that data at your fingertips in order for quality improvement to truly be driven. We can give organizations that information so they can understand in real time what's happening with their patients to drive those clinical practice differences that result in the better outcomes that we talk about in terms of lowering prevalence, improving healing rates, and reducing complications and regulatory fines as well.
Sure. So there's two forms of prevention, right? There's primary prevention, preventing the initial wound, and then there's secondary prevention, i.e., preventing that wound from reopening or other wounds from being generated. How do your models deal with those different I guess estimates? Because I know in our models we ask the same question: what's the probability of the initial that initial risk for the patient, and then subsequent, and those subsequent ones can be far more expensive than the initial.
And so the primary prevention that we offer, a lot of it for the years since we started in 2016, we've had tools that are widely known, like Braden, incorporated into our data set. And so that clinicians are collecting them. And then it starts off even just with dashboards where organizations can look at who are those patients that are at greater risk and monitor them. And when I was in nursing school, Braden was in full force in terms of being adopted. And then the big shift became, okay, you can have a Braden score, but what are you doing about it? And that's what Swift often can help organizations. And one of our more recent papers was saying, okay, we have this Braden score, but to your point, how do we use statistics or a machine learning approach to understand what is meaningful in this change? Because when I'm a nurse at the bedside, I might see that last week they're 18 and this week they're 13, but it's very hard to get clinicians to fully look at the entire data set and how it's changing, but a model can. So one of our recent papers was looking at a time series analysis, which again, I think is a fascinating thing that organizations can do, working with statistics people like yourself to better understand what are signals versus only designing a tool like a BWAT, a push to be used by the clinician once, but how can models tell us more? So we had some early insights to what signals we should look for in terms of changes on specific subscores, as well as the period of time, 21 days specifically, is what we found significant. If there was a score drop, they were at much higher risk for developing that pressure injury.
No, I read that paper. It was fascinating because and we'll put it in the show notes, but I believe the paper is called "Improving Pressure Ulcer Risk Assessment Using Real World Data from Skilled Nursing Facilities," and it's in the International Wound Journal. What I really enjoyed about the paper was the use of a survival model on the one hand, and it's a Cox proportional model, which is super cool. Just as an aside to the audience, not a big fan of Kaplan-Meier. I will release a podcast about that because it's highly technical, but it's important. But the Cox proportional model is very useful, very flexible, and I like the way that your research partner really used it to provide estimates of that risk. And then the other thing that I really liked about that paper was disaggregating the Braden score. So one of the challenges with the Braden score is that 216s can have very different underlying. So, you can't look at a 16 and say, oh, well, this is the risk. Well, what is their underlying scores that led to the 16 or the 9 or the 7? And those patients can be very, very different. So if you would, let's talk a little bit about that paper in terms of the disaggregation of those Braden scores, because I think it was fascinating.
So in that paper, one of the things that the R&D team was looking at was, again, how can we take this wound prevention tool and improve how it performs? And we did forward, backward kind of passes on looking at the model and which elements are going to provide a more predictive power or lower predictive power. And in the paper, we talk about which ones had the most. And one of the questions we got from the reviewer is that, oh, does that mean we should get rid of these tools or these subscores in the Braden? And we said, no, that's not what we're looking at. We're trying to see what's creating a meaningful signal or alert for the deterioration. So day to day, we may need the different subscores, and we weren't challenging that or intending to create a new tool. But what we're interested in is the large organizations that we work with have not just hundreds of patients or thousands, they can have tens of thousands of patients that they're trying to understand. So how do we create signals to them without having to look at a 16, but to look at their data set. So we were trying to raise that as the opportunity as we can create better dashboards and reporting functionality that helps you say, okay, yes, this 16 is a 16, but this 16 is the one you want to look at because they've had this deterioration in the signal in these specific subscores and the um, recent score change.
No, that's brilliant. We're also kind of going down that road of I have a love hate relationship with the Braden. I think it's an incredible tool in the real world because it's less ignorance is better than total ignorance. Right? A little bit of light in the darkness is better than no light at all. But it has inherent weaknesses as a scale. And I think that people try to think of it as a prediction tool. That's not really what it is, at least in my mind. It's a tool to create observed data relative to clinicians and how they're understanding the patient's risk at that time point. I really love the work you guys are doing there. There's two things that we're looking at, which is in terms of what is called item response theory. So this is very popular, like for educational tests, like SATs. So a lot of times, educators have to figure out which students are actually understanding the work versus those that are guessing, right? So
Mm.
you could have a test, let's say out of 100, and then you have to get two 80s, right?
Yeah,
How do you know which is the true 80 and how do you know which one's not the true 80, right? And so
I'm glad I've done
IRT.
school.
Exactly. Exactly. They need to figure. SAT guys use this to figure out which students are actually understanding the work, and so a lot of what you're describing relative to the Braden can be understood through that framework. There's what's called the rash model, which is where you say, okay, I am going to regress on the items, and then if I have a big enough sample size, I can estimate the latent traits that are going to really tell me which one is really at risk, right? So that's the rash model. And then you can make it even more complicated. There's three parameter models. And so I'm super excited about that work because that's where I think the true power of the Braden comes is when we're building statistical models that are able to um, guess this latent trait. Like there's a latent factor in that patient that this data is telling us. And these models can help us tease out what the latent traits are that really indicate that the person's truly at risk or they appear to be at risk, right?
Absolutely. And I think that's what our goal was is creating a better tool. There's limitations in every tool that is out there, but it doesn't mean we should get rid of it. And we had an interesting conversation. Matthew, the researcher that I was collaborating with on writing up the clinical implications of this, talked about how in the UK they're moving away from Braid and going to a much more subjective tool, which I'm sure people have thoughts about. I don't know the full details about it, but the data can be analyzed and we can figure out how to improve it. And my understanding was they found that the completion of the Braden tool was inconsistent. There's subjectivity and there's problems with it, which is why I think the opportunities that we have with AI to understand the data that's in a system or that we can automate the analysis. So, for example, as I talked about with smart tissue, what do we need to train clinicians on and what do we want clinicians to do is an important question to ask ourselves, because if I could have a app that just tells the clinician this is the best treatment and how you should cleanse a wound and do that, that's the most effective use of their time. And I think in wound care specifically, we know we're a subspecialty that not everyone has training in. So how can we make the need to go to a specialized course? I took a 2-year program to become a certified wound ostomy and continence nurse. Not every nurse is going to do this, and there's huge gaps in primary care and other places. So how can we give the tools to say, I can tell you this, and as a clinician, this is what you should be doing about it, is what fascinates me in understanding the data and tools we're creating.
No, that's a great vantage point. It begs the question. So, when thinking about AI and machine learning, and I know people are using these terms, and a little bit of my history was that I did practice management and managed a group of 50 providers in 400 nursing homes. So I had to think about the different levels of provider. All of them were
Mm-hmm.
certified as wound care specialists or CWOCNs, but there were different levels. You had someone
Yeah.
had 2 years of experiences versus someone has 20 years of experience. So I guess my question is, in terms of AI, and in terms of the problems that it can solve. Um, I look at wound care as an 80-20 problem, in the sense that 20% of the cases are just complicated and need a very high level of expertise, whereas the other 80%, you need to identify the lever or the set of levers that you need to hit quickly.
Mhm.
How do you think, if I framed it that way as an 80-20 problem, where do you think AI is targeting? Is it targeting that 80% or is it targeting that 20%?
I think right now, 80% for sure. I think it needs to start with lower complexity. And we're looking at, again, automating parts of that clinical documentation. I've seen papers published looking to automate the PWAT or a subscale. So I think the simple parts, and going back to our prevention conversation, if we can get better documentation, and we can also help that 20% that is really complex, maybe not even develop to the complex point. And we can talk about some of the predictive work that we're kind of doing, and that is also really exciting to me because it's a huge challenge. Is how do you take a wide variety of skill sets and collect as much data? And we had a research project where we launched a application for patients called Patient Connect, and they could simply take a photo, and we weren't showing them because of some of the research coverage that we had, the measurements and the output from it, but allowed us to collect the same level of information because once we get that photo and that calibrant, we can do that on the back end and provide it to clinicians. So similarly, with different levels of regulated healthcare professionals, how can we collect the maximum amount of data without pushing their scope? Because they could take a photograph without assessing the wound, which might be beyond their scope, but the model could still do the assessment piece and help the wound care team or someone like Janine that's overseeing the entire wound care program. So that's something that our SVP of client success thinks about. It's like when you have these tools, how do you implement and fit into those different levels that you're talking about to maximize the use?
No, that's fascinating. Let's talk a little bit about the predictions. I mean, you've mentioned it. Could you walk us through the prediction models that you guys have been working on, and what are the problems that you're trying to solve for these models?
So, as I mentioned before, we have the algorithm wound severity. It's called Healing Index. There's a paper out on that that we published a few years ago with Rishab Gupta, and it generates using the objective wound measurement, the tissue types, and some elements of clinical documentation to create a severity score. And so we are doing a number of pieces of work in terms of research and what can we do with severity score, because the score is just an output, but what you do with it creates fascinating opportunity. So we had a recent poster where we were looking at the wound prediction. And so PAR, I've heard you talk about this before, and the 4 week mark, it's known in the different wound types. The percentage of healing can be an indicator. Is this going to be a chronic or hard to heal wound, I should say, or is this going to heal acutely and you're less concerned? So we did a comparison, and there's been another AI model that was also looking at improving on the PAR 4 week model. And when we did our comparison, Healing Index could outpredict surface area reduction at 4 weeks. The interesting part, too, that we were sharing when we were presenting this work is not only did it outperform it at 4 weeks, at 3 weeks, it also outperformed it. And at 2 weeks, it outperformed it. So over time, in those early stages, we can better predict which wounds are likely to be challenging to deal with. And our healing index at 2 weeks was nearly as good as that surface area reduction at 4 weeks. So we can buy a clinician 2 weeks on that time to understand. So those areas of prognostic are things that we're trying to understand. And again, figure out how do we escalate these wounds to those experts who are overseeing entire wound care populations in order to actually act on that information.
No, that's fascinating. In that cohort of wounds, was it predominantly uh, pressure ulcers, or was it a mix of chronic wounds?
It was a mix of wounds. So our data set, because a large amount is built on skilled nursing, but we also have home health, you can think of the major wound types: diabetic foot ulcers, pressure injury, venous leg ulcers, and arterial ulcers. being well represented in that data set. In addition to predicting the likelihood of being a hard to heal wound, another application that we found for Healing Index was creating an escalation dashboard. And this is something we presented at SOC in the spring because we started to use this with a enterprise home health organization, and they're doing thousands, tens of thousands of evaluations in a week, and there's no staff that's going to be able to review all that documentation. So from a quality improvement perspective, we said, how about we take a look about being a second set of eyes and looking at how Healing Index has changed. And if it shows deterioration, we can send an alert for a review by the clinician manager for that branch. And so we were able to get about 52% acceptance for the reports that we were generating. And the interesting part was there's 22% that they found were helpful, but there were quality improvement issues. So the majority of cases, they were saying, yes, this is helpful. The clinician had said this is improving, and it was only the improving wounds that we were doing this safety double check for. And then they were able to escalate and start their pathways for providing advanced care for those patients because there was some deterioration. And then for the other portion, they found that there was a quality issue. So perhaps the imaging and documentation was done on the wrong wound location, or there was a tissue product left on the wound bed when the photograph was captured. So the smart tissue reading was not accurate. So they were able to say, oh, I can actually tell the nurse that took this image how to improve their quality and use that as an opportunity to kind of learn and improve. So this is another application of this severity score. So it can range from quality assurance monitoring to prognostic. And the more we understand, again, this data, the more we can think about what tools will be useful and how can we use it for organizations trying to improve wound care programs.
No, this idea of this latent frailty or index score. I mean, Dr. Fife has kind of developed a model around that. Her own index model, or her team's index model. You guys seem to be doing it, and we've been working on it particularly for pressure ulcers, trying to understand what the latent frailty score is, and playing with a couple of different models. I talked about IRT, but also what are called sequential ordinal models, which are a little difficult to understand because what you're estimating, you can never truly know. Right?
Mm-hmm.
Like you can never observe what the actual frailty is. All you can observe is how the wound changes over time. And so having that ability to use the data you have to estimate that frailty score for not only a general cohort of people, but for specific patients over time. It's a challenging problem. It's a challenging problem. And then, to your point, explaining that to clinicians, right?
Yeah.
Because clinicians are going to go, well, I see this, and as a statistician or an AI guy, you say, well, I'm not trying to estimate what you're seeing. I'm trying to estimate this thing that we can't see that will help you guess better. And they go, what? And so it's translating that statistical or AI inference back into the real world. That's a challenge.
So I learned, maybe I've known this for a while, but posters at wound care conferences traditionally get a lot more traffic if there's some wound photos. And that prognostic model and some of the advanced machine learning posters have area under the curve and things like that. So I'm always standing in front of the poster being like, no, I promise you this is going to be really, really interesting if you just let me explain the math behind it and what it's going to do for you. But next time I just got to maybe put a few more wound photos to draw people close to it so that they get excited.
So, Rob, one of the things that I find very fascinating, given your cohort of customers who are in post acute, is pressure ulcers. I think pressure ulcers are not studied as often as they ought to be. I think they're complicated, they're super expensive, and once you get to full thickness of 3 or 4, they are very difficult to heal.
Absolutely.
So, what has been some of your learnings around pressure ulcers, given the data, given some of the work you guys are doing?
Yeah, we are so fortunate to have just a enormous amount of real world data. And we've published a paper with one of our large enterprise skilled nursing facilities who adopted the technology too. So in seeing multi-year use of the technology, and this organization had hundreds of facilities, so they could compare on how outcomes change for the sites that had been able to adopt the technology and the sites that had not yet been able to adopt. And so the improvement of pressure injury prevalence by 13% and supporting those organizations in what you talked about before, that primary prevention, is phenomenal to see in the data when we look at 2021 and 2022 data. So organizations have opportunity to drive these quality improvement initiatives that other guests on your podcast have talked about when they have tools that can give them the information they need to understand and truly classify the wounds correctly, ensure there's proper treatment, drive quality improvement. And we saw faster healing times as well in the organizations as they treat them, because they're able to see in real time how the wound is progressing and responding to the treatments that are being provided. And that ability can help over time is in how they manage them. And so we saw both in stage 3 and 4, which you talked about, better outcomes and reductions in time to heal, which can lower costs. And so these add up to time for the clinician being saved, but there's also bigger implications. And if we think about the drivers behind adoption, pressure injury, litigation, the costs associated with them, is one of the reasons that we have a large operational footprint in skilled nursing, because of the impact that we can have and the driver and motivation for them to improve outcomes. And this organization also saw a reduction in citations as well, dropping 88.9% of the FTAGs, the citations that they were receiving in facilities using digital wound within their wound care program, compared to only a 19% reduction in facilities that were similarly trying to adopt the quality improvement strategies, but just not as effective. So overall, providing clinicians with the right tools allows them to actually deliver these outcomes that they're trying to move towards, because it's so challenging, especially to understand a wound only from narrative or drop down menus in a wound EMR, what is truly happening. Because when we read those descriptors, everything in your mind can create a different potential wound. And so seeing the image, having objective measurements, having dashboards, and the ability to communicate as a team allows organizations to change their practices that drive those outcomes.
Sure, that's pretty outstanding results. F tags are another interest point for me. Again, I came from post acute, and one of the questions that I think is interesting, separate and distinct from the pressure ulcers by themselves, is how do nursing homes navigate the F tag world? For the audience, an F tag is a regulatory citation that nursing homes receive if they don't do something right. And there is one in particular for pressure ulcers in wound care. And that's F686. And I think Pamela Scarborough talked about it in the previous podcast, Janine McGuire, and I oftentimes talk about it a fair amount. And so the work you're doing there is really valuable, because if those tags occur, there are oftentimes other penalties that come into effect. Civilian monetary penalties is one of them, CMPs, and also the star rating, which is how the building markets itself can be impacted as well. So it's a multifactorial threat there that you're dealing with.
Absolutely. And it's interesting to think about the US landscape being different from Canadian, but one of the things that I see as a Canadian is that attempt to drive behavior through regulatory and sometimes the kind of civil monetary penalties you talked about. And that's the negative driver of it. And we're trying to come on that positive side and saying, here are the tools that allow you to deliver that care. Because I believe it was Pamela that was talking about the F tags are supposed to make sure that good quality care is being provided. It isn't like inherently trying to be a punishment system. It's trying to say these are the things that you should be doing inside of your wound care program to prevent pressure injuries and to ensure appropriate wound care is being done. And the challenging part as a nurse that I think about is if I'm at the bedside and I don't have the tools to easily document, to make sure a care plan is in place, with the many things that are on my plate, that is it leads to burnout. And we see that in a lot of clinicians, and it's very much talked about in the industry. So how do we create tools that let people do what they need to stay in compliance with the auditors? But often doing that is driving these outcomes that we see in reducing prevalence and helping healing times, because they have the tools to actually implement the care plans, the follow-up, the referrals that are needed.
No, absolutely. Just as an aside, there's an interesting piece of research that we did, and we looked at a state's F tag regime and the probability of a wound tag for facility given its geographic location. Here's a little bit of inside baseball. The F tags for a state, not are oftentimes done by different teams. And those
Mm.
different teams sit in different geographies. So we looked at Pennsylvania, and in Pennsylvania, there are 5 or 6 offices that send out these auditors to do the tags. And in one of the regions, the probability of a wound tag, all things equal, was like 7 times more than any other region in the state. And when
Oh,
you looked at the underlying, skin integrity scores, they were not atypical. There's a, you know, there is endogenic things that are going on at the facility in terms of quality,
yeah.
certainly, but I think there's exogenic factors as well. That is, what is the propensity for that field office to cite people for the exact same thing that's happening in another region? So that's another confounding thing in the FTAG system.
I can only imagine as I continue to learn and delve deeper into this, it's fascinating to understand the dynamics and everything that goes into it. And yeah, I do get emails rescheduling meetings because auditors have shown up, and I know that's never a happy message when I see it. So I think it's important that we have these dialogues about how is the system being developed and how are we creating tools to allow people to easily navigate it so it doesn't become such a anxiety inducing and negative experience.
No, definitely. It's kind of interesting because I came from it from the provider perspective. It's interesting you coming from it from a tech company's perspective, and it's the kind of panic that sets in at those times. I don't think it's healthy for anyone, and a lot of times it's unnecessary. But again, I think that's a discussion for another podcast. But we could talk about that for 3 hours. So we've got about 5 minutes left. 2 questions that I'd like to kind of delve into. The Canadian health system, you're aware of the American system and some of the challenges that prevail here. If you could spend a little bit of time talking about the Canadian system with its provincial NHS-like setup, it's fascinating. If you could just walk us through what that looks like and what wound care looks like, and what's the auditing system in Canada.
So we have a very different and, as you said, nationalized healthcare system. So it is actually not nationalized; it's publicly funded nationally. So you can think of our federal government as flowing dollars in to the system to make the majority of costs, but then it goes down to our provinces, version of states and territories, in order to deliver that. So the decision making comes at the provincial level. So we, in fact, have about 13 different health systems because they can all take their own approach to things. We don't have a CMS setting federal program approach, even though there are local determinations. There's more variability within Canada, but the benefit is what is medically necessary is covered. So as a Canadian, I don't have to hold on to insurance, and some of those things become much simpler for me. But then I'm sure, as you're aware, there can be wait times for specialists. It's need dependent, and there that can be parts that are lamented by the Americans who are hesitant about a publicly funded system is the wait times. Yet the insurers or payers in the U.S. seem to be barriers or gatekeepers in different ways. So in terms of as a clinician, what I saw, some of the barriers is that because of the lack of business models, such as the reimbursement programs that happen through CMS, there's less business related innovation and development that gets adopted because there's not necessarily funding mechanisms purely around payment codes for every industry, and hospital organization budgets are pretty limited. So we spend a lot of time understanding where is the financial impact that we're having, and a lot of that time is created demonstrating the impact to the payer or the government system. And that can vary province by province, how they understand their cost models or how they pay for it. Where we've seen opportunities is to move up from the provider level to those provincial conversations. So an example of that is in home health organizations. So in Canada, we've worked with a number of organizations, and we can see positive outcomes for those adoption in terms of the healing rates, the reducing complications, and dealing with quality issues that they see. And so we're in discussion to take that data to regional bodies in Canada. In my province, that's the Ontario Health at Home. And so you're always trying to figure out how does the funding kind of flow. It's just a different system and where it kind of comes from. And you asked about the regulatory side of it. our clinicians are regulated in each province, and we don't have the same level of auditing and compliance that the US does. We just don't have a penalty system. A lot of our organizations go through accreditation, and that's a annualized or a process where auditors come in and go through it, but it's not associated with a penalty system. It's associated with a recognition that they're providing good quality care within the clinical programs that they have available to them. So we still have quality checks and opportunities to demonstrate that. They're just not the same uh, approach that the US has taken.
It's kind of funny that Canada has a more decentralized system in terms of caregiving than the United States. I think a lot of people would think that would be inverted, which is kind of hilarious once you can think about it.
It can really vary. I'll give one quick example of that. So, Alberta, very large province in the western part of Canada, and Ontario, the province of I'm in, Alberta has a centralized medical record approach because they're under a single governance structure for the Alberta health system. In Ontario, the government invested in electronic medical records, but they took dollars and gave them to organizations and allowed them to pick and choose. So you have a wide variety of different technologies in the landscape that we as a healthcare organization or a software company have to think about the adoption pathway. So there's lots of these kind of funny things that happen in publicly funded systems that you just have to understand how is it evolved in the financial kind of landscape in order to make pathways for change of clinical programs or adoption of technology.
It's very interesting. What I've noticed also in wound care is a lot of Canadian companies, that innovate in Canada but bring product here and iterate it in the United States. So just off the top of my head, you folks, Mimosa, Kent is another one that springs to mind, and then in
Yep.
the EHR space, PCC. So it's kind of interesting how these Canadian companies bring product to bear in Canada, and then skipping over the border to kind of iterate it at scale.
Absolutely. There's an abundance of Canadian research and innovation because the government continues to invest in research, economic commercialization. So we have a variety, and it's kind of fun to see that Canada is filled with innovators and researchers, and the US absolutely provides a great opportunity for adoption. We're definitely thinking about how we grow success on both sides of the border, but it is one of the things that the US system does so well is adopt new technologies and integrate them into care with all of the different financial models available in post-acute, acute, and the continuum.
That's brilliant. Well, we're coming up on our time here, and the last question I ask everyone is the Wound Genie question. So, if you had infinite time and infinite money and infinite resources, which is the one problem that you would solve or attempt to solve in wound care?
The challenging part for me is if I try to skip to the solution, there's so many things that I want to solve. So I'll go back to what I think will help. And it's something we discussed earlier is the perfect data set. And we work with a ton of organizations, but there is often limitations to how much data they have. So in skilled nursing, you have full residential kind of picture and a lot of their medical information in one place. But then you go to home health or primary care or hospital, it's fragments. And as you said, in order to truly develop better tools, we need good data that we can rely upon. So I think that's the one thing that if every project that I worked on could easily have the perfect set of data and there was that wide variety of access and it was well formatted and ready to use, I think we'd be in a great place for the many minds and listeners of this podcast to do some really cool things.
That's brilliant. As a data guy, I'd like to second that uh, as something that would be absolutely brilliant. Well, Rob, it's been a fantastic hour. I thank you for being open and coming on the podcast, and I appreciate the work that you and your team are doing to help clinicians, to help patients. I think at the end of the day, that's all that we're trying to do, and that's to help people with wounds and to help people make better decisions about wound care. And so I thank you for your time and I look forward to speaking to you at SOC in a couple of weeks.
Thank you so much for having me. Total pleasure. And yeah, I can't wait to continue the conversation in person and hopefully meet the other people who like to nerd out over the show.
Brilliant. Thank you so much.